Hello, everyone. I'm Azhar Hirani, and this is our next episode of Practice Unlocked. I'm here with Dr. Jignesh Shah, who is a gastroenterologist. Did I say it right?
Or a butts and guts doctor.
Butts and guts doctor, or let's say GI doctor. He is part of a very big, large group practice in Houston, Texas, and also he is the former Indian Doctors Association president. So, Dr. Shah, welcome. And then I have my co-host here, Priya Bhaskaran, as well.
Yes.
Perfect. So let's get started. You can do your own intro much better than I can. Even though I have your intro here. Please, please proceed with what you do. What's your experience been like? Just everything about you.
Sure. It's hard talking about yourself, in an open forum. But thank you, Priya, and thank you, Azhar, for welcoming me onto this podcast. I've heard great things about it. But a little bit about myself. Grew up in the East Coast in New Jersey. As you can tell from the twang I have, a little East Coast and Texan and Indian accent, combination of all. We immigrated when I was 3 years old. I immigrated to India with my mom and me and my brother. Then my dad followed in suit for a bit and learned a lot of things from my mom growing up of hard work. And from there, education was our principal background. That was drilled into the family. Really liked helping others. My mom, as an Indian family, physician, lawyer. That's all they believed in. But fortunately, I believed in helping others. So then went to med school, started training, grew up in the East Coast. Then trained out at University of Louisville in Kentucky. And then decided, hey, should I do private practice, do academics? Then decided, hey, private practice or academics, either are very great fields. But what more inclined me to come to Houston, Texas, was my wife. She actually liked the Texas, and my brother was here in Houston, and she wanted a big family support, and I personally liked academics. So my background was I trained in pediatrics, and then trained in internal medicine, certified in both of them. Then I loved taking care of kids. However, I got tired of the parents until I became a parent myself. Right. And then decided to stay back in Louisville and do a fellowship. Academics is where I strongly believed in because I love science. Love science. But then Houston was on the map, Florida was on the map, and Jersey was on the map. So great opportunities in Houston, absolutely great opportunities. So decided to stay back in Houston. Been here since 2010. Been here in private practice with a group practice for 13 years.
Wow. How big is the group?
So we've ranged over years, ranging from 9 guys up to 15 MDs, not including our allied care professionals, which are PAs and nurse practitioners.
Wow.
And plus we have office staff over 100 employees and with surgical centers, not including the surgical centers. So, and we take care of the southeast region of Houston, a GI practice with 5 offices and 3 surgical centers. Wow. The main reason is to help with different geographic patients, accessible for GI care quickly and readily.
No, love it. So when you started, did you start as an associate and then did you become a partner, or you bought into the partnership right away? Or also, did you always wanted to be in a group practice, or initially you thought, hey, I'll work for the hospital, or I'll go solo? Like, what was your thought process behind all this?
So my thought process was initially stay back in Louisville. Just love academics, had opportunities there. But my wife wanted to raise a family. We wanted to raise a family, and we wanted a diverse background, a lot of diversity, and she thought Houston would be the best place.
Love it.
So interviewed at a bunch of practices in Houston, right? Starting from 1 or 2 man groups to corporate medicine. Because as you know, there's nothing like Texas Medical Center. One of the best in the world. In the world, right? So there's some big players here, some great academics. They said, let me try this private practice model with a bigger group, with the younger physicians, and with the spectrum that maybe we can grow this, right? And at that time, it was a small practice, and there were young and older physicians, a combination, both different levels of experience and different stages in their careers of their lives.
Right.
So decided, hey, this is the group for me. So in medicine, especially in the private practice model, there's 2 sorts of setups, right? A solo practitioner that you can be associate when you join. They want to see if that relationship is something that you can build on. So making you a partner right off the bat doesn't really exist unless you open up your own shop or
Makes
open
sense.
up your own practice. Even academics, same thing. So they see if you can get along with them and they can get along with you, and it's a good synergistic thing for the business of medicine. So that's a practice I joined, right? So offer, usually with those kind of private practice models, you have a partnership track. Just like in any other company, there's a partnership track, whether it's
Right.
1 year, whether it's 2 years. And after that, then there's sometimes in medicine there's ancillary incomes, especially if you're in a field of invasive or interventional procedures,
Makes
like
sense.
surgical centers, surgeons, gastroenterologists, cardiologists, so nephrologists. So there's other ways you can incorporate ancillary income.
Right.
As then that's the business of medicine, right? And those
Right.
ancillary incomes actually are in benefit for the patients as well, because you can provide quicker services, readily
Absolutely.
services at a lower cost.
Absolutely.
Right. So sometimes people think medicine's a great lucrative industry.
Right.
Actually, times have changed. Times have changed greatly, and you think twice before you opening up an office or a surgical center, because sometimes you have to close the doors. And
Yeah, just if
unfortunately-
you just rely on just patient care only, you have to
Right.
like add on to that practice. That's what you're saying. Like either be ancillaries or partnerships or other ways of generating an income at the same time taking care of the patients as well. Because number one priority is taking care of the patients. But if you could provide the same service where rather than them going outside to do it, you rather do it in-house. Is that kind of, that's what I'm kind of getting at.
Me and Priya were talking about this just before we started this, and saying you gotta really truly love medicine.
Makes sense.
But let's be real, okay? But if you love treating patients, you still gotta keep your doors open,
Yes.
right? You gotta pay for your office staff. You gotta pay for your operating expenses.
Yeah.
There's expenses that tend not to go down year after year. And as you guys know much better than I do, every year maybe taxes may go up.
Yeah.
Your payments may go up for your employees. 401k plans will be changing, evolving.
Absolutely.
Healthcare insurance changes over time. So how do you do that, right? And unfortunately, med school doesn't teach you that. Your colleagues do, your friends do, associates do, right? So how do you figure that out, right? And you don't want to learn the hard way. That's the biggest problem with younger physicians coming out. There's not a mentoring or coaching program.
Yeah.
Right? Unfortunately, med school doesn't provide it. Residency doesn't provide it. They provide you optimum patient care, but not the business of medicine. It's not taught.
Where did you learn the business of medicine? Like, did your group actually help you? The nine, kind of partners or associates that you kind of, the group that you joined, was that like a big influence on you, or was it like you're just networking with other physicians? It was a combination of both, or your own experiences? Please kind of dive into that.
So, I guess me coming out, I wanted to try something different, right? For me, I wanted to try. I don't know business, right? I don't have an MBA. I didn't have an MHA. I just had an MD behind my name, and I wanted a group where I had spectrum of diverse physicians, not strictly a single ethnic background. I wanted physicians at different stages of their careers, people who have a lot of experience, over 20, 25 people who are out within the first decade of their life. That I would lean on them. My goal was to lean on them, right? Going into, and sometimes what you expect and what you get into are also different. Right?
Yeah.
These expectations I'm going into, but how do I choose? The only way I chose is from interviewing at different practices.
How many did you interview?
Quite a bit, actually, more than 15 practices.
Wow.
Or open up something solely, or joining corporate medicine.
So how do you know which model fits you and your purpose? Because is it guess and test? Do you have to just figure it out as you go along? I mean, how do you know that this is the right fit? Like, what made you pick, out of doing all the numerous interviews that you did, what made you pick your destination?
That's great. I mean, it's sometimes soul searching, right? In your residency and your fellowship. Sometimes we learn the hard way in medicine, and going into this because there's never a partnership track.
Okay.
What I always tell younger physicians, make your 5-year goal and make your 10-year goal. What do you want to do in 5 years? What are your expectations? Do you want to raise a family? Do you want to be a high research person? Do you want to be a guy who develops new technologies? Do you want to be or make a lot of money, right? With good patient care. So if you can figure that out, those 5 or 10 years, then that's where you start interviewing.
Yeah.
And depending on what opportunities then come. and Houston, multi-diverse.
Yeah.
So many opportunities, right? So for physicians or younger physicians, it was a place to go. Now, if you're prone to a certain location, like I want to say in Seattle, I want to say in Jersey, I want to say a certain area of Florida, rural medicine is sometimes one of the most financially sustainable practices for
Makes sense.
physicians because there's need.
Yeah.
Right? There's a need base.
Yeah.
But remember, if you do that, joining private practice, recruiting someone is very difficult. Rather, you join a hospital-based position because they will help you recruit. Because if you live if you live in Tyler, Texas, nothing bad at Tyler, Texas, beautiful city.
Yeah.
However, very hard to recruit.
Yeah.
However, financially, it's very profitable.
Lucrative, yeah.
Right?
Yeah.
But remember, that means you're going to work. You are going to work.
Like call coverage and like things like that.
You are the person.
Yeah.
You are the go-to person depending
Gotcha.
on what specialty you are. Something goes wrong, they're going to call you, right? They're going to depend on it. Then you start building these relationships with patients, families. It's hard to say no. And that's where you get into the bind of like, damn, I signed into something I shouldn't have because now I don't have that work-life balance.
Right.
And there is no such thing as work-life balance in medicine, honestly.
Yeah.
In medicine, as you know, you told me your mom was a physician. And you've seen her, like, go get her, right?
Yeah.
And then you go, shit, do I really want to do that?
Yeah.
You know, do I like? And my girls watch me too. They go, Dad, like, where's the work-life? There is not a really work-life balance,
Yeah.
and that's the truth.
Yeah.
If you are thinking that you will obtain a work-life balance career, it's
Yeah.
not the field.
Yeah.
It is absolutely your commitment to medicine, or as well is super. Even your patient care. But then, if you don't want to run your own office, you just work for a corporate. Academic physicians work really hard too, right? They're teaching, they're doing research, they're seeing patients. They're not taking care of the business aspect of it,
Right.
but they're still busy.
Yeah.
Right?
Yeah.
They're busy.
But there's a trade-off, like in terms
There's
of
a trade-off.
financially, like so if you want to be more financially, what's the word I'm looking for? Like if you want to continue growing financially and take the benefits of your work year over year, you would say that okay, going private or going with a group practice, you're able to achieve that. But if you don't want to deal with the business aspect, you don't want to deal with the hiring, the firing, things like that, you always have the academics to kind of lean on or even start off because that's what your passion is. You don't want to take call. You're thinking, hey, from an institutional level, either I do research or I see patient care, I still have backup. I could go home on time, enjoy my weekends, have vacations, spring breaks, things like that. Correct? Yeah.
You're absolutely right. I mean, everyone always, as a physician, if you talk to physicians all the time, some of them are frustrated with the bureaucracies of medicine.
Huge.
Bureaucracies
It's a big
of
problem right now.
Healthcare,
Yeah.
bureaucracy,
Yeah.
insurance companies. I get frustrated. However, if you want to make changes immediately within your own practice, private practice is the way to go.
Yep.
If you want to make global changes,
Mm-hmm.
academics is the way to go.
Makes sense. Okay, that's a beautiful way of putting it. I
Yeah.
never thought about it that way.
Like
Because-
locally versus globally.
Yeah,
kind of thing,
exactly.
Yeah.
Yeah, I mean, like we serve a 35-mile population, right? But some
Right.
of our patients, my partners and I, and we're very diverse. All of our ethnic counts, right? We get patients 100 miles apart, right?
Wow.
But we're serving. But if we want to globally make a big difference, I think the academic person is going to make much more global difference than we are.
Impact. Great.
And as well as all of us have academic positions. We love teaching. Some of them teach residents, some of them teach med students. However, that academic physician, even though they're frustrated, in the long term, I think they're going to make a huge impact, right? So going back to the 5 and 10 year plan, think of that before you decide what you want to do. It's not test and try it. Because if you test and try 1 year, you just lost 1 year of your life. Not lost it, you sacrificed and put the commitment of 1 year of yours where you could have probably built something stronger.
That makes sense. So like they should start thinking that prior to med school or during med school or after med school, like ideally.
So
Yeah.
the med school structure is it's a very long, tedious process, right? I think in the United States,
Yeah.
this long process makes you in debt,
Yeah.
right? And that debt, you got to really start thinking because you do 4 years of undergrad, 4 years of med school.
Yeah.
After the 4th year of med school, you got to figure out what you want to do, right?
Yeah.
You want to do internal medicine, you want to do family practice, you want to do OBGYN, you want to do all these different fields,
Yeah.
right? And that's another, depending on what field you choose, it can range from 3 years minimum to 5 to 6 years minimum, right? And that doesn't make you specialize. So then after that is another 3 years for specialty, 2 to 3 years specialty across the board. So now if you think about it, you're looking at 14, 15 years of just training.
Yeah.
Right? So you start processing that information as soon as you hit residency, right?
Okay.
Because you got to really figure out location, geographic. You got to find someone who's going to coach you. You got to start finding mentoring. And sometimes, you guys know, that physicians like talking to physicians.
Yes.
Yeah.
That's the worst thing.
Yeah.
I mean, I learned more from Azhar, and I learned more about little tips you can give me about broadcasting than I would learn from anyone, right? I think networking forums are great for physicians to reach on business and talking to others, see what the different market shares are.
Yes.
Right? What region do you want to live in? Try to find a group in that region, start talking to them and see, is this what I want to really do?
Yeah.
And where I want to go with my practice. Do I want to do corporate? Do I do private practice? But solo practice medicine in the next 5 years, I don't think it's going to be sustainable.
Yeah.
I just don't see that.
Is it because the costs are high, labor costs, or just running with just the patient load? Let's say an average physician sees 30, 35 patients a day, which is a lot, by the way. Still, they're not able to sustain their practices, or the patient population, like our insurance companies making it a little bit tougher for patients to come in. Is it what's really driving the model where you think, because I've heard that from a lot of physicians that, hey, for the next 5 years, they see a lot of practices being bought out by hospitals, or corporations are coming in and buying up private practices. So why are some people getting into practices, and why are some people not able to sustain
It's
their
a
practices?
fantastic question. It's a question that is real life, right? So I guess which customer is going to be impacted the most? The customer that's going to be impacted the most is the patient.
Yeah.
Reason is, right? Patients have want full accessibility to healthcare immediately.
Yeah.
If you're sick, you got a tummy ache, you want to get to see your doctor right away. What happens when you call your phone saying you have a 3-month wait? What are you going to do? Go to Google, look up the next urgent care, or next someone who can see you like this.
Yeah.
Right? Accessibility.
Yeah.
Private practice offers accessibility.
Yeah.
We all know that, right? Because patients want to be seen, private practice want to be busy. As Azhar said, practices can be seen from 15 to 30 patients a day, 35 patients a day. In academics, it's tough to see that much, right? So that's why their waiting period is so long. That's why it will take you 3 months, 4 months, 5 months. They have a set block, 30-minute intervals, 60-minute intervals. Our private practice can modify their intervals as needed.
Yeah.
Right.
Sometimes there's such incredible clinicians that they can figure out what's going on just talking on the phone, but they want you in the office to figure out, to examine you. They can maybe get you out in 10 minutes.
Yeah.
But in academics, it's a little harder.
Yeah.
The whole, because you wait an hour to 2 hours, and the volume they can see is limited because of the bureaucracies of medicine.
That makes sense.
Scheduling, how to do that process of it, right?
Yeah.
In private practice, you can set up that process by yourself, right? So more volume. So getting back to the question is, how many patients can you see, right? How would you choose it, right? Depending on the person, how many patients you can see a day.
Yeah.
And then the cost of medicine. Like when I started my practice, I recruited a medical assistant, right? She started right from school, picked her up. Fantastic. She's my right hand.
I think I know who you're talking about.
She is my right hand.
Yeah.
Right?
So,
she's
fantastic, by the way.
Grow my practice incredibly.
Yeah.
I'm telling you, she can be a physician herself, but she never wanted to go to med school, and I always forced her to go to PA or NP school. Come on, you are so brilliant. But if you foster your staff and help them grow, sometimes it's always not about the money as well. It's about the relationships you're building with your office staff.
Absolutely.
Taking time, treating them as a true person, like you really care for them, and that you honestly do care for them.
Yeah.
That what do you want to do? What are your needs? How can I help you? And she's been on my side for 13 years, and I always tell her, this is our practice. It's not my practice. You help me build this. My patients, some of my patients like you more than they like me, right? So if you want to do private practice, you got to be ready to do something like that.
Absolutely.
You got to take care of your office staff. The cost of business is going up. Every 1 or 2 years, her salaries increase no matter what.
Yeah.
Without hesitation.
Yeah.
Right? It's just standard. But I don't think she really stays there. But however, we know the cost of everything else, fuel, food, gas, is going up. So we're not going to maintain everything. However, now the reimbursements I'm getting, we're seeing those 25, 30 patients has gone down.
Yeah.
Like we think it would go up.
Yeah.
It has not. So I'm seeing 25 patients, maybe I make a couple $1,000. this year, next year maybe even less.
Yeah.
While her salary is going to go up.
Yeah.
My office staff is going to go up. My rent's going to go up.
Yeah.
My taxes. So how can you sustain?
Makes sense.
You can in private practice, adding more partners.
I love that. Okay.
So even
You
with
can.
the private practice model, you can add more partners and still not be classified as a group.
So a group structure
Okay.
can be solo practitioners with group MDs.
Okay.
And the structures vary depending on what region you're going. Houston is a very competitive market. For take instance, gastroenterologists. As of 2 years ago, there were 264 private practice gastroenterologists just in Greater Houston.
254.
More than 264.
264.
More than a few
Okay.
years ago. Private practice,
Yeah.
right? That's crazy.
Yeah.
Right?
Yeah.
That's just crazy. And the problem is the biggest group is literally ours.
Yeah.
And that's still kind of, oh my goodness.
Yeah.
Why can't we all come together
Yeah.
and work cohesively together for the better interest? So so when you come out, you sort of want your way, how to run the stuff, run everything. However, if you decide that, remember, you got to hire staff, you got to run your office, you got to hire these, because you're so busy seeing patients.
Yeah.
Yeah.
Right? At the end of the day, then you got to take care of everything else. You're going to get burnt out.
Yeah.
You will be burnt out. So if you had a partner that can work synergistically, you got to compromise. As we know, we compromise in everything. Then you had another partner, you had another partner, you had another partner, depending on the partnership track. Then in those partnerships, the structures are different across the board.
Of course. Yeah.
Right?
Is it RVU based or?
Yeah, so the first year, if that mutual stuff things, I would strongly recommend sitting down with the person you are possibly going to become a partner to go over how the structure is going to be. It's something called eat what you kill model.
Yeah.
Is whatever you see, you keep the profits, and then you pay back the overhead. Yeah. So sometimes the overhead, and number one question to ask, what is the overhead of your practice?
Yeah.
Is it 20%, 30%, 40%, 50%? Another question to ask is, what's included in the overhead?
Yep.
Okay. These are very critical questions to ask, because once you sign partnership and you're a partner, separating afterwards is very tricky.
Very, especially because new partners or new associates are seeing a lot less patients, I would assume.
They are.
But they're sharing the overhead of their part or the overall practice.
So when you're associate, you don't you come as a fixed income.
Gotcha.
Anywhere you join a private practice model, you'll have a salary-based position.
Gotcha.
And then if you exceed that salary-based position, there'll be some sort of compensation formula. Right? As if you're saying about 20%, if you hit this mark, if you see 30%, you hit this mark. And that's intentional, and I believe in that aspect because it makes you a go-getter.
Absolutely.
And provides better care. You come to the office, reality is you can't see 5 patients a day.
Yeah.
That's the truth, right?
Yeah.
You see 5 patients a day, that doesn't, I know the patients.
It doesn't add value to the practice
It
or
does
yourself.
not.
Yeah.
I mean, it doesn't add value to the community.
Yeah.
You can't keep your clinics for 1 patient for 2 hours. You just can't do that.
Yeah.
You got to serve a greater good. Even in academics, you can't do that. So you got to keep a set volume of patients. So when you join as an associate, you should work hard. Okay. I truly mean work hard in the sense see more volume of patients. If you see those volume of patients, then you'll understand how much you're getting paid. When you're an associate, you can there's something called ICD codes and CPT codes, and you don't learn that in med school or residency. You don't, and that's something you're gonna start teaching yourself, right? And then if you're in a bigger practice, you can talk to your business practice manager.
Yeah.
You can talk to, hey, can you pull my billing codes? Can you bill what I'm getting reimbursed? So give you a sense before you join partnership, right? Then you can figure out, oh, I collected this much. Okay, by the way, what's my overheads, right? What's the overheads included? Now, what does my partnership agreement look like? Is it equal? You're 30%, you're 30%, I'm 30%. Or is it you're 80%, I'm 10%, and you're 10%, I still categorize as a partner.
Right.
So the structure varies. Okay. What's a fair structure? I don't know. Hard to tell you, right? Sometimes it's saying, I've been in this practice 30 years, so in kind, right? So sometimes if that's okay with you, it is, but for some others it may not be. You may want to be equal partners.
Gotcha.
Everywhere. Structure in our practice, everyone's equal, right? Everyone brings value to the practice.
Yeah.
Right.
So when you decide to join partnership, you figure out what value you're adding, and you be very objective to that. Objectivity in the sense of what did you financially gain at the end. What other services are you providing that your group is not providing?
Mhm.
And so those are objective matters that help you in negotiation.
Love it.
Right? So, hey, I see, like, Azhar is my, here, me and Priya. Priya is the only female gastroenterologist in the Southeast region. Damn, I can't beat that.
Yeah.
Objectivity.
Yeah.
Priya collects maybe 100,000 a year, right? My other partners collect only 50,000 a year. Gag.
That's value. Much
Yeah.
more valuable. Yeah.
No, and you're giving objectivity on your negotiation table.
Mhm.
Yeah.
Right?
Got it.
Priya is a hard worker,
Mhm.
right? And that's kind of subjective,
Yeah.
right? But so because I work this, but I tend to hear younger physicians always say that. I work from 6 to 9 o'clock, 6 to 8. That doesn't fly.
Yeah.
Or in private practice models, your senior partners have been doing this for 15, 20, 30 years. That doesn't fly. So you had objectivity.
Yeah.
Right?
Yeah.
Collections, work ethics, always available, always picking up the phone, team player. These are objectivities when you get back onto the negotiation table.
Yeah.
And now if you think that negotiation is not going well, it may not be the practice for you.
So, one important thing I really want to touch on that is and this is true in any business, to basically fast track yourself into partnership is get more referrals. So it's not that patients are walking in and a physician's not seeing them. They also have to go start building the relationships to get the referrals into the practice, correct? Because it's not a walk-in model where a patient walks in and the senior doctor goes, oh yeah, the junior doctor will see you. It's not like a barbershop model.
Yeah.
Like, you're not going to a barbershop
Yeah.
and say, hey, John, come here, he'll take care of you type of deal. It's more like, hey, for the patients, you have to go to the primary cares or go to, places where, you can start building that relationship with other physicians so you can starting to get referrals.
Mhm.
And also another way is marketing, how to market yourself, where are you like in terms of either be online, either be in other places, publications, what are you doing to get new patients through the door? That's value, correct? I know we didn't touch on that, but can you kind of go over
that's
how they
great,
can do that?
Right? Priya, you have a choice as a patient, right? If Azhar was a physician, I'm a physician,
Mhm.
right? There's 10 people on the wall,
Yes.
right? You have a choice, right? You can pick him or not. But your primary care doctor sends you to Azhar.
Yeah.
But hey, I don't really like him. I'm
Yeah.
gonna see Jignesh, or vice versa.
Yeah.
So that hits the point,
Yeah.
right? Objectivity, right? Doesn't matter if your partner has referring doctors, their patients have a choice,
Mhm.
right? So if you're not a go-getter, if you're not marketing, if you're not increasing your volume and shaking hands, unfortunately, even though you may be a great physician, if you don't market yourself, you won't be able to keep those doors open.
Yeah.
Right?
Makes sense.
However, if that's the situation, if you're a great physician, you're not interested in marketing, you're not interested in academic practice is the way to go.
Got it.
Because your clinic will be full. Your clinic will be full, for
Yeah.
sure, right? But if you like to hustle, if you like to meet people, if you like to socialize, you like to network, if you want to make an impact immediately, you gotta market.
Yeah.
Right? Sometimes practices help with you, group practices.
Yeah.
Versus solo practice. Now you're saying, hey, I just want to do my own thing, right? I want to open up my own shop.
Yeah.
You can do it. But then, as you said, you gotta market, you gotta get out there. People are not gonna come to your door.
Yeah.
How did you do it? Kind of with your experiences, so the other physicians that are watching this can kind of get an idea that, hey, I'm doing A, B, and C, but Dr. Shah is saying D and E are important too. That maybe they should start doing that as well.
So the practice area, there were different people, all different stages,
Mhm.
and we saw people probably going to retire in the next 5 or 6 years, while there were younger physicians
Yeah.
that we can change,
Mhm.
and sort of watching them,
Mhm.
watching how they market, watching how some did, some didn't, some were very busy, but that helped me look at different people in a different way, saying, oh yeah, that's working. Oh yeah, he's really laid back. Oh, this is how aggressive. So you got to figure out what works for you. Right. For me, I like interactions, right? I like going out, hanging out. I like outdoor stuff. I like patient care. I like talking about patient care.
Yeah.
So that's where I go. I need to market. I need to start marketing. I need to start meeting people and provide good care, right?
Yeah.
And put in the extra hours to learn the business on your own. And there's questions. You have someone to lean on, right? You can say, hey, show me how this works. But if you don't ask those questions, no one's going to give you the answer.
I agree.
Yeah.
Yeah, if you don't ask, you
that
don't.
question, if you don't ask that question, or if something doesn't work, no one's gonna openly tell you that. And that's real medicine. That's the business of medicine. You have to figure things out on your own.
So in terms of, let's say, I'm a physician who's just starting out. Okay, I am about to join your practice or any practice. Let's say now I don't have any patient volume right now, and I know in a lot of practices there's a lot of phone rings for new patients all the time, and I know the senior partners are pretty much tied up and are very busy. So they usually take turns in giving those new patients to the new associates that are coming in or future partners that are coming in. So that's one way I could get more patients. The other way is to meet other doctors, to send referrals our way. Where should I go to meet other doctors? Because I know there are a lot of networks out there, but let's say primary care A has been sending to another doctor for years and years and years and years. It's hard to change referral patterns.
Absolutely.
So how do I break into that mold and say, hey, I'm also your guy? I know you're sending to the other gentleman or another physician, but I'm also your person that you could send to me as well. I'm also an option. So should I send marketers to that practice, or is that one way? Should I just reach out, go myself to that physician's practice and say, hey, can I take a little bit of your time? Can we go for a lunch or dinner? Let me introduce myself. Let me start a relationship with you. Is that the right approach, or just kind of give everyone just a glimpse of what they should be doing?
Yeah, that question you asked was great, because if you're considering joining a group practice as an associate, number one question is asked is what you just asked is, how are your new patients distributed?
Yeah.
Right? Because the senior partner maybe have 15 patients blocked.
Yeah.
If he can't handle the patients, how is they distributed afterwards? Do I have to go get my own patients, or is there an overflow of patients in that practice?
Yeah.
If they don't have an overflow in that practice, the expectations is you have to bring your own business.
Yeah.
It may not be the perfect setup.
Yeah.
Right. And so that's one great question to ask if you're joining a big group. What's your overflow?
Yeah.
How many patients are you expected? But you are expected to generate your own business, right?
Makes
You are
sense.
expected to market. And remember, there is going to be overflow in big practices. That's where they're looking for someone to join.
Makes sense.
Okay. And ask the amount of overflow. Second thing is to look at how do you market yourself, right? Once you get into the practice, 3 to 4 months into it, start figuring out what region are looking at primary care physicians, right? If you're a primary care physician, then also looking at specialists, what specialists are in your area. Depending on what you feel and do your research of what
Makes sense.
and start knocking on doors yourself. Remember, a personal handshake from a physician to a physician goes a long way. Instead of sending your team out there, you may, if you're a physician, you don't want to probably see my team. You probably want to see me at least saying, hey, thank you for sending these patients. Thank you for letting me take care of them.
Yeah.
And then the follow-ups can be your office staff. Another great resource is local societies and medical societies.
Yeah.
For instance, in the Southeast region, become a member of the Harris County Medical Society, Sugar Land or Fort Bend Medical Society. Great network, instantaneous network of resources, from liability, physician resources, practice providers, networking events. So wherever area is not new to you, if you're moving from a different state, join that society, medical society, and you'll get more resources in there if you're trying to do your private practice model.
And I know you were the former president of Indian Doctors Association, and it's would that be considered a society, or would that be considered like an association for physicians? And it's more, I know it's more on a charitable level. It's more on a level of social. It's on a level of, kind of a way to kind of bounce ideas, a way to do CMEs. It's basically an organization, a group that can organize physicians very quickly. 100, 150 physicians at just one email. So I know that's very important for people to join, and there are other associations like that they should definitely look into as well, besides the ones that were mentioned, like the Fort Bend or Harris County. They're county level organizations.
So associations, personally, Indian Doctors Association would not be, if would be part of leadership, would be too difficult. right? Because you're creating your own private practice model. You're creating that, so you'll be so busy doing administrative stuff that I wouldn't recommend those kind of associations.
Yeah.
Because that requires a lot of time, right?
Yeah.
The reason I personally joined it was more philanthropic, right?
Yeah.
To give back, to make change, to grow.
Huge impact, because you're making a direct impact. I know. Yeah,
Right?
exactly.
But the way, if you want to gain some resources, is medical societies
Medical societies.
of that town or that region. For Bend Medical Society, American Medical Association, TML, there's a lot of associations in that area. Have to become a member. Membership includes fees, right?
Yeah.
Some of them are substantially higher than others, but you have to try that. You have to try it a year, 2 years, because they have resources of how to build your office, resources of a lot of unbelievable resources. I can't believe to tell you.
Oh, they do like seminars and things like that? Oh, really?
They do CMEs, they do educations. Comes with a cost.
Yeah.
Right? But
It's an investment.
It's an investment on stuff you don't know how to do.
Yeah.
That you can lean on someone saying, hey, teach me how to do this. Show me how to do this. And they'll give you 100 different resources and you paid for membership.
Love it.
So when you graduate residency or fellowship, I would recommend the last year of your residency or fellowship, become a member of that society a year in advance, right? So maybe 2 years, it's worth the investment you put into, without doubt.
I love it.
I think it's kind of crazy that I guess going to medical school that they don't have a program for the business and marketing side of that, because you are essentially selling a service or a product, which is you. And I would just think that medical schools would add that type of program to help, medical students that are actually trying to pursue a career in.
Absolutely. I guess, I'm sure there are reasons why, because obviously they want to move them into more institutional type medicine.
Yeah.
That, because they're always affiliated with that.
Mm-hmm.
Like I know a lot of the colleges, a lot of schooling is affiliated with bigger hospitals.
Both ways. To be a devil's advocate, right?
Yeah.
If I was taught the business, which I totally agree with you, I think we lack that. However, think about the flip side of it. If you start learning all the business, you're more consumed on the finances, not on their health.
Yes.
The human aspect.
Yeah,
let's
let's forget the cost of it. Let me just take care of you.
Yeah.
You're the. However, real life doesn't work out.
Yeah.
So that's the main reason they don't want to distort money.
Yeah.
Yeah, I just want to take care of you. Whatever I need to do, I need to take care of it. I
I
don't
love
want to
it.
worry about this pharmacy drug is this much, the imaging is this much, that you don't have.
Yeah.
I don't want to think about any of that.
Yeah.
I want to make it happen for you. I got to make it happen for you. How do I take care of you?
Yeah.
So it's the flip side.
No,
But
I like
then-
that. I love that answer. Yeah,
But then,
Yeah.
then you think, damn, no one taught me this when I got out.
Yeah.
How do I get insurance approval for that drug? Wait, it's not paying for it. Hey, I sent this code in. It was the wrong code I built for it. And that's when you go, I wish. But you're so naive, right?
Yeah.
They're introducing medicine to you.
Yeah.
And that's another reason. The new generation, if you want to go into medicine, truly love it. Because business has changed.
Yeah.
Healthcare has changed.
Yeah.
And for the next 10 years, it's going to change even more.
No doubt. Now, I know that you mentioned your team. Let me just kind of go back to, I know the person you're talking about, because I know when my mother, who's your patient, when she was scheduling her appointments and things like that, this would she be considered MA, or she an MA, or this MA, she was tremendous. I mean, called my mom up, and it's difficult to go around the system to kind of get the appointments, figure out how much is it, when should they come in, what the procedure is, prior to the procedure itself, things like that. So, in terms of invest in the team, but do you have like further team members as well that kind of come with you, describe with you, so when you're just sitting with the patient, you have someone writing all the notes and everything, and you're approving everything at the end of the day? Do you have someone that is doing all the prior appointments, the post appointments, basically running the shop while you just look at patients? Because a lot of physicians do it all. I've had physician practices I've gone into that the physician is actually at the front counter.
Yeah.
I kid you not, because
Closing
the volume's
out,
so
yeah.
the volume's so low that he was literally in the front counter,
Yeah.
and he's seeing patients and he would like welcome them in.
Yeah.
That's an extreme example, but I have seen that.
Mm-hmm.
And then I've also had physicians who only had one person in the whole practice running the show, including, being the front desk, being the office manager, taking the vitals by the time that the doctor comes in. And it's not the right, because in their mind it's like, oh, I'm cutting cost, but it's like on the flip side it's like, hey, it's an investment that's actually going to help you increase the volume. No marketing in the world is going to work if the patient experience is not as smooth and as comforting as possible.
I agree. That business setup would not last over a year, 2 years. You'll eventually find out financially, and he's going to get burnt out. He or she will get burnt out.
Absolutely.
You can't do it all. I mean, sometimes we have to let go, right? Hiring, depending on what specialty you're on, right? If you're in a surgical field with a medicine field, there's people in the back end office, right? Sometimes you can have someone overseeing the whole practice called a practice manager that takes care of the business aspect of it. Then you have a nursing manager that takes care of medical assistants, takes care of the registered nurses on the back end office. So, and there's another team called prior authorization team, right? And that helps you authorize medications, authorizes imaging studies, laboratory testing, or procedures. What authorization means is if you have Blue Cross Blue Shield, and I recommend that you have an ultrasound of your belly because you were just hurting, your insurance is gonna say, I'll pay you $300.
Do you really need that?
You
That's
really need that. You know, it's like, you really, like how you do it to your kids. So like I told my daughter, she's always wanting this, and my younger one, 6-year-old, always wants a toy. I go, sweetheart, do you really need that? Same thing with the insurance company. Do you really need that ultrasound? All right, am I gonna pay for it? So you have a team. That's gonna put the right code in, right there. If you miss something, they're gonna say, hey, Bria, I think you need to go back and look at your note because we're not gonna get a prior authorization, and the patient's gonna be super upset, and they're gonna have to pay $300 for that images and beside what they paid you. So a team for that, and usually you have 2 or 3 people depending on how many providers you have. Then you have someone, you work, you want to get paid. Unfortunately, say the collection, if you look at collections with AR, right, it's really bad in healthcare.
So like bill charges versus what you collect, essentially.
Tell me, what do you guys think would be a good collections charge in there?
Well,
You'll be mind blown when I tell you what the right average private practice model of collections is.
I would know, but I know that being in medicine for 15 plus years, not as a practicing, like I'm not a physician, but being in the business of medicine, I've seen so many EOBs, which is explanation of benefits.
Do you understand any of those?
I don't. I still don't. So I was going to say that being 15 years in this business, I still don't understand it.
And each insurance company is different in how they explain it.
Exactly. And I know you have a ton of experience in collections and billing.
Part, of the insurance. And they'll deny it for something very frivolous. Like, it's very
But I'm so curious to know exactly what the percentages of what the bill charges would be. A good guess for me.
For a private practice model. Established private practice of more than 5 physicians, which are going to be aggressive, right? Because they want to get paid because of all the work. What do you think? What do you think that number would be?
I would say, and
you have a business mind. That's what I'm asking you.
I would assume if I'm billing something, I want to get paid 100% of what I'm billing because that's a fair number. In the ideal world, they're not going to pay me over, but at least pay me what I bill because that's an accurate number. It can range, but I know I've seen 25%. Of bill charges, but also depends on every practice builds differently.
So you're saying 25% collections,
but that's if your bill a certain way.
I was going to say 60.
So $100 you're planning to get $30, $25.
According to bill charges.
$60.
According to bill charges.
So a good sustaining practice after a year, if you look at, and that's a great question to ask if you're joining private practice, where are your collections?
AR, what's your AR and what's collectible?
Our easiest way is where you bill, what do I actually collect? What does the practice collect? 30% is a great practice.
Oh, okay.
It's a great practice.
So you were closer with
great practice.
Because I've seen it. And
20% is still a good practice. 30% is you're running a tight ship.
Wow.
That means your business manager. So not your the credentials person's doing great. Your business team who is billing and coding, all the codes are green. They're on top of the insurances.
Appeals. All the denials and the appeals.
Remember, some providers, like if you had a busy day, I want to do the notes the next day, the notes the next day. You only have a certain time before you see that patient to bill. Otherwise, it gets denied.
Yes.
Right? They will find for specific reasons, every right to deny your claim.
Yes.
Of course.
So your billing team has to be exceptional.
Absolutely.
Because all the hard work you put in, they have to collect that.
Yep.
Right? So that billing team, the credentialing team, or not prior authorization team,
Mm-hmm.
then your medical assistants or your RNs.
Yeah.
And there's also a triage in your front office. That's just office-based practice, right?
Wow.
So you have to have this team, because then that helps you build more volume,
Yeah.
helps your collections,
Yep.
and helps the experience, right? The patient experience, right? It's if you come in, you have a nice someone greeting you,
Yep.
taking your insurance, checking you in, giving you an iPad, then the medical assistant bringing you out, getting your vitals, then the nurse talking to you in the room, then the physician coming in.
Yeah.
You have multiple areas of good medicine.
Yes.
Good medicine, right? Instead of one provider doing everything or one or two, it just doesn't sustain it.
Yeah.
Yeah.
However, the flip side is you gotta pay everyone their salary,
Absolutely.
right?
Yeah.
So that's just the office-based practice. Now, if you go into an interventional field like
You add-
surgical ortho,
You add more
then
layers
you
to
add
it.
more,
Yeah.
many more. Then it starts
More
growing.
staff.
And,
Yeah.
and that's it. That's maybe a good thing that you enjoy doing, right?
Yeah.
Is you're growing that thing, and then you can reduplicate that model somewhere else. Reduplicate that model something else, as we see in ERs.
Yep.
Right? They simple little ER, it's working fantastic. Let's duplicate it.
Yeah.
Somewhere else. Let's duplicate it somewhere else. Same thing with healthcare, like office-based practice. It's working, duplicate it.
It's scalable.
Yeah. Exactly.
Exactly.
It's
That's the
scalable.
perfect
Yeah.
word.
Yeah.
Perfect word. It's extremely, but remember that requires a lot of time.
Yeah.
So if that's something, but you will make a huge impact, right, in the community.
Absolutely. Now, in terms of everything that you said, okay, the prior authorization team, the triage team, or let's say the back end team of things, especially the collections team, especially like the office managers or MA and things like that. Some of it can be. It doesn't have. You don't have to employ them, right? It can be there are third party companies that you can hire if you're starting out and you just need someone for rather than needing someone for for a full set of 8 hours a day, 9 hours a day. There are third-party companies who you can kind of lean on, correct? If you're starting out, because I've seen a lot of physicians nowadays, they take their laptop to see the patient, and they're the only ones that are taking, and talking to the patient. But in the background, they've hired someone that is taking notes on Zoom.
Oh, yeah.
So like, I got curious, and they were like, yeah, this is the third party I hired, so I need the staff. I just don't have space in my office.
So it's kind of like a virtual assistant.
Yes,
type thing.
yes, but that's just an example. Then I was like, oh, do you have a collections team here? It's like, no, that's outsourced.
Mhm.
He's paying I think 5% or 6% of collections to that team. So it's all these things are needed, but you don't have to do it in house as well, correct? But
So-
if you become a big practice, you need that in house, I'm sure.
Even with big practices, you can outsource.
Okay.
Right? Outsourcing, main thing is what are your charges, right?
Yeah.
For my build, if they're able to collect 40 or 30%, it's a great building company, right?
Yeah.
So,
Wow.
but I'm only charging 3% or 4%, great building company. You can try it, and it can be outsourced to any of the countries, and a lot of people do that. But sometimes it's better kept in-house,
Yeah.
right? Because you can keep a closer eye on it. You can train if you have the right person, get them back in. So beside the office staff and beside associates and partners, there's another bucket. That bucket is called allied care professionals. Allied care professionals mean nurse practitioners and physician assistants. And they help your practice greatly.
Yeah.
For instance, our practice intentionally has allied care professionals. What they do is they're trained very well, they're licensed, and they see patients for you. However, each patient, they're supervised by physicians,
Yeah.
right? So if you want to generate volume, if you want to add to lifestyle, right? We practice as, I think, close to 8 or 9 allied care professionals.
Amazing.
All of our lifestyles are much better, right? Because they do a lot of our work for us in the sense of seeing patients,
Yeah.
right? Writing notes, writing medications, doing
Yep.
phone calls, lab checks, and plus you're supervising, right? You're still seeing the patient,
Yeah.
right? So that helps quite a bit. Another resource is scribes,
Yeah.
right? So that the variation between those two professions, the scribes are lower salaried,
Okay.
right? Don't have to really be a lot of healthcare knowledge because they're just standing and they're doing all the work and like typing, you're dictating and they're typing and taking care of
Yeah.
that thing, and helps great, because if you're seeing 25, 30 patients a day, you gotta write 25, 30 notes a day,
Absolutely.
right? While allied healthcare, the other nurse practitioners, we actually will take care of everything. Right?
Yeah.
But the cost is much more.
Yeah.
For them, seeing their salaries and compensations are much more, but they will never be partners or associates.
Of course not. Yeah.
Right? They're just employed 1099s or
Yeah.
employees of the facility.
Can they be on like a profit sharing plan usually? Or they won't be partners, but can they be on a profit sharing plan, or in healthcare that's not allowed?
It is. It's actually allowed. So
Okay.
they can be on, not, I wouldn't say, I guess, profit sharing for 401ks.
Or maybe a bonus plan, or
They can be incentivized.
incentivized.
Right?
Yeah.
And medicine allows incentivization, right? Even corporate medicine does, right? So recently, it's something called Medicare came out with the incentive program. The
Mhm.
government did, right? To provide quality metrics.
Okay.
To become a better physician, if you do A, B, C, D, E, F, G, and you submit this data,
Yeah.
I will compensate you 1 or 2% more every year moving forward.
Okay.
And Medicare came out with this.
Yeah.
Right? So I think it's awesome.
It's amazing because it's a
Awesome.
win-win-win situation for the patients, for the physicians, and the insurance companies, the governments, any way you look at it, and the winner comes out actually patients.
This, being a devil's advocate,
Yeah.
some physicians hate it.
Oh wow.
They think Big Brother's
Absolutely.
watching me,
Yeah.
right? Both ways to look at it. It makes you a quality physician, it incentivizes you. However, the government knows everything about your practice. Every little
Wow,
thing.
yeah.
Everything.
But technically,
But,
Big Brother's
okay.
always watching anyway.
Exactly. So it's
The
a little,
EMR,
Yeah.
I mean,
younger
everything's in the
physicians
EMR,
or
yeah.
younger people in
Yeah.
their careers, they don't really care about that,
Yeah.
right? Like, and even I tell some of my older friends, who cares, right? You're gonna retire in 5 or 10 years. Well, what's the big deal?
Yeah.
What's the big deal? It's a headache. I know, but they're quality metrics.
Yeah.
We should be doing this.
Absolutely,
We should
regardless
be
of an
doing this.
incentive or not,
Yeah.
it's the best way to practice
The
medicine.
best way, we're making sure if you have diabetes, something called hemoglobin A1C
Yeah.
is checked every 6 months.
Yep.
That's a check off.
Yep.
You smoke and you come to me and said, hey, smoking's not good. That's a checkpoint.
Yeah.
I actually address that with you.
Mhm.
So these are quality metrics. These are very, like you guys are, body mass index is your weight per your height,
Mhm.
has to be a certain threshold.
Yeah.
If we don't talk about that, that's not a good thing.
Yeah.
Right? So that's also another checkpoint. So these are great checkpoints.
Yeah.
And the government's monitoring that.
Yeah.
So incentivize. Same
Love
thing
it.
with our PAs and MPs. Good practices will incentivize you.
I
If
love
you
it.
see 20 patients, 30 patients, or 40 patients, if you see above a threshold, we are going to incentivize you, right? And in the big picture of that incentivize, overall the practice is doing much more financially better, right? So it's where, if you're looking, even if you're an allied care physician, if you're looking for a job, make sure you have some sort of bonus structure and look at your bonus structure, right? And a good question to ask is, the last person that joined, how much bonus did they make? That's
Yeah.
another good question to ask, right? I mean, maybe you think these thresholds are not meetable. The thresholds are always negotiable.
Yeah.
So you can renegotiate that threshold.
Yeah.
No, I love it. Now I know you're in a group practice. Do you guys run it as like single EIN entity, or because there's huge benefits to that, right? The bigger the practice, the more negotiating power you have. But not only the insurance companies, but also a lot of the ancillary businesses as well that you could be a part of. Start compliant way.
Mhm. So in Houston, as we said, the act of doing business of medicine has gone up really high. So smaller groups, 2 or 3 men, it's not sustainable to keep your doors open, right? Because it's just not. You work so hard, and at the end, you're taking out so less, because you're paying everyone, and so you're doing the right thing.
Yeah.
So now we're seeing the big trend. The trend is joining bigger groups. Numbers are power.
Yeah.
Right? Congress, we know numbers are power. So number of physicians, the bigger the group is, the bigger negotiation power we have with the payer, which is insurance companies.
Yeah.
Right? So we're a pretty good big group.
Yeah.
But then we started seeing the trend in the last 3-4 years. So we started looking at options. Let's get some things on the table, right? What are we going to do? Are we doing private equity? Private equity is a big company coming in and buying your practice out and putting an office manager or their business, street smart business, making this more lucrative, or getting Azhar to come and say, hey, you run this practice, show me how to make more money out of this practice.
Yep.
Selling your practice to them, right? Or joining a big corporate industry, big players in town, right? There's so many different practices. So we decided about a year ago that this is the way we want to go, because we're seeing the cost of medicine go higher, and we're seeing reimbursements go down.
Yeah.
And even though we're a big group, the payers are bigger than us.
Yeah.
Of course.
They have more power. So we said, let's join a bigger, much conglomerate, or join a private equity group. And that's what we did about close to a year from now. And growing pains, of course.
Of course.
Of course. Financially, very good. It was stable. It was very good and lucrative. However, we didn't enter it for that sole reason. We entered it more for their aging physicians, retiring physicians. We have younger physicians. How are we going to sustain at a global level?
Yeah.
In a private practice model setting. And that's where we decided this is the right course of action, and we've been happy so far, all of us.
Amazing. Did you have that vision, like when you joined 13 years ago, that, hey, you know what, this is a big practice. Eventually, as we grow, at least there's an option to exit.
I had no clue.
Wow.
Honestly, I had no clue in the senses. I thought the private practice model was sustained forever.
Yeah.
I didn't know business.
Yeah.
Right? I didn't know anything. Then when I started learning all this, I go, oh my God, what did I just get myself into?
Yeah.
Of course.
I was like, oh my God, this is like so overwhelming.
Yeah.
Right?
Of course.
And I go, and everything I said, like, as you said, I'm doing all this work, I want to get paid 100%.
Exactly.
Right? It's everything's fair. No, it's not.
No, it's not.
The payer is saying, no, it's not.
Yeah.
All right, this EOB, do you know how to read a EOB? I go, no.
Yeah.
I have no idea what all this mumbo jumbo means.
Yeah, and patients come. Patients
even
literally.
physicians.
Yeah.
Physicians
Patients
don't
bring
know how to read
printouts.
it.
Yeah.
Patients bring
If I
printouts.
repeat, I go, what does all this mean?
Yeah.
And denials. We see denials 24/7, right?
Yeah.
And then when I call the medical director to talk to him, saying, hey, just let's talk this out. I go, oh, no, it's approved. Like simple things that the bureaucracy of medicine.
Yeah.
Right? So, but you got to be patient with it. You got to figure it out. And then when you start seeing your numbers saying, hey, long term, is this sustainable?
Yeah.
And that you learn within the practice,
Of
right?
course,
You start learning it, and then you're looking at, I think we need to, then you start needing to talk to your partners. You need to try to get everyone on the same page. Everyone has to agree to something. It takes years. And finally, we were at that point that majority did say, yeah, I think medicine is changing. We need to exit.
Yeah.
Or not exit, still sustain. Exit in a way that we still have some control of this region. And that's where you choose a good selling point is, do you really want to exit
Or
you
good,
wanna
partner.
exit the whole entire practice and get a very nice lucrative buyout and you're done? Or do you want to exit with still involvement as an employee, or exit still as a partner or as a shareholder? Different aspects of it,
I see.
right? So
Or a combination as well. Sometimes it's a combination. Yeah.
So 3 different avenues. Exit, I'm done with healthcare. I just want a nice payout. I'm done. I'm 60 and I'm done. Right?
Yeah.
Got a nice pay. I don't want to deal with healthcare anymore.
Mhm.
Or I just want to be an employee. Just give me a fixed salary. Give me a nice payout. I'm done. Oh, hey, no, I don't want to exit totally. I want you guys to come in. I want to make this more successful. I want a nice payout. Plus, I have some say. I want to be a shareholder. I have some equity into this company. Right?
I love it.
So any of those 3 possibilities are open. So if you decide at some point in your career, look at those very closely.
And one important thing is, I see a lot of physicians who want to retire, and their retirement plan is selling their practice. And they literally think they'll sell their practice and walk away. But the thing is, they're not looking at it as, they're not buying your practice. They're technically buying your MD badge. Like, meaning they need you to run this practice until they recruit another physician. It's not like this company that's going to buy you has already recruited a physician and is ready to roll into your practice and get started has started where you kind of left off. It doesn't work that way. So I always tell physicians that, hey, just kind of look ahead, that when you are selling the practice, sell it earlier than you need to, because you're going to end up, the expectation will be that, hey, you need to transition out slowly if you would like to, or at least be an employed physician for a certain amount of years until the transition is done. That is the only way you'll get somewhat decent payout. And also another thing is, it's very surprising as a solo practitioner, the kind of payouts that these companies will give them. It is way lower than what we buy businesses for.
Yeah.
Oh, that's crazy.
Yeah.
I would think it would be higher.
No, it's
Yeah.
much lower.
Yeah.
So that's something when
Yeah.
you join our private practice, and
Yeah.
you say, I don't want to deal with any of this. I'm just going to open it up. Have some friends who are going to help me in this. Trust me, think before you go into that aspect of it.
Yeah.
Because a solo practitioner cannot really sell his practice,
Yeah.
right? Because you're still bound to that practice for all the rules,
Yep.
right? Patient charts. They're buying your patient charts. They're
Yeah.
buying the patient lives that you're attached to. But who's going to take care of these lives?
Yeah.
They don't have providers to take
Yeah.
care of them.
Yeah.
Right, so they won't let you exit in that way by any sort of
Yeah.
circumstance. So no single private practitioners are able to sell that practice.
Yeah.
They have to shut the practice out, and they have to freely give it to someone else without any compensation.
Exactly.
And we've seen it in this region that they try to sell it, nothing happened. They try to sell it, but then they finally have to give all their patient lives to someone because that's a board requirement.
Yeah.
Yep.
A medical board that you cannot leave a patient stranded.
Yep.
You have to have some follow up. Someone has to take care of your practice because that's the right thing to do.
Yeah.
And so, being a solo practitioner, rather you join corporate medicine because the differential isn't that much.
Yeah.
Right. And the tax bracket in the end, you're still taking over the same. Plus, you added so many headaches to it.
Yeah.
Right. So if you want to start your own thing, unless you and 2-3 other people are joining together, you and 3 friends in residency or fellowship saying, I want to stay in this region. You guys are like-minded. If you do decide to do that, have everything clear cut.
Absolutely.
Business is business.
Yeah.
Yeah.
Right? Friendship is friendship. Friendship goes bad in business. And we always talk about this in my group.
Yeah.
Is I always say it's 50-50. Some people say business is business. It's 100%. There's no friendship. However, if you want to do business, you got to be friends with the person.
Yeah.
Of course.
You got to have a collegial, you got to have a nice environment that you can work in.
Absolutely.
I never
Right?
like those sayings like business and personal
It's
because my
not.
business is personal. Like
It is. And I believe the same way,
Yeah.
right? If we're going to be business partners, we got to like each other.
Yeah.
Right? We got to like coming to work together. And we're going to profit from it. So we're going to
Yep.
share some things you let go, but it's not exclusive 100%.
Yeah.
So if you are deciding to build your own private practice with a couple of people that you like, sit down with their attorney, sit down with the CPA, put it on hard paper.
Yeah.
And everything clean cut before you start growing.
Yeah.
Different opinions happen.
Absolutely.
Put everything in writing, and it may be like, no, even especially if it's family.
Yeah.
You're going in practice with your brother who's a physician or a sister, put it in writing. Saying, no, we're good, we're just family. Doesn't work that way.
Yeah.
That's why, so then that's when the business comes in too. Saying that's why, make sure you have everything clean cut before you decide to grow, build, or start a practice.
No, that's great advice. I think our, we're going to start wrapping up. So any,
Well, I do have one more question before we
or
start.
I actually
Yeah.
know the question you're going to ask.
Uh-oh.
And
Is
she's
it gonna be
been
a tough
itching.
part? Is it gonna be a tough one?
Yeah.
No,
No,
it's
no,
tough
definitely.
for me. For you, probably
It's
easy.
something that I've been researching a lot. I know
Yeah.
AI is taking over
Oh,
pretty
yeah.
much every industry. So I wanted to hear from a physician. How do you think this is going to impact the healthcare industry?
I'll tell you a funny story. My brother works for AT&T. He's the head of automations, AI.
Wow.
And he always teases me. You're gonna be out of job next year. You're gonna be out of job next year. I go, when? Can it come sooner? 'Cause the reason he says that is AI, bots, robotics, in all specialties, from Da Vinci machines, as we know, Da Vinci's are these big, expensive robots that are driving all different specialties.
Yeah.
And every specialty has AI now involved in it. There's I won't take the hospital systems in, but there's a hospital system that's using bots for scheduling procedures.
Yeah.
Scheduling what 10 people can do, that automations is running it.
Yeah.
Wow.
It's already implemented. It's been
Wow.
starting since the last year. For in the GI hemisphere, there's something called GI Genius. GI Genius is an AI software that when you do a colonoscopy, the reason you do it is to look for abnormalities.
Yeah.
Right? Like polyps. Polyps are little growths that can turn into cancer. So this little machine is now hooked up to the scope that once you're in the colon, these boxes appear telling you, hey, you missed something.
Yeah.
Hey, you missed something. AI.
Yeah.
It takes away the human error.
Yeah.
By the way, fun
And
fact,
we started doing that.
where they showed this off,
Yeah.
I was on that CME.
Oh, okay.
Yeah, people are looking around saying, you're not a physician, why are you here? And I was like, this is some brilliant stuff.
Yeah.
Like, I was very much intrigued by it. So I stayed through the whole CME
Yeah.
without being a physician. I was pretty amazed by
Yeah.
what, you
it's
know.
mind blowing for
Yeah.
physicians. We complain about it because we hate older physicians usually hate technology.
Of course, yeah.
Because
Yeah.
there's a lot of changes in it.
Mhm.
So a couple of my physicians when we spoke together, he sees all these boxes. He goes, "Stop that! I don't want to see that. I'm tired. My eyes are better than that machine." And I go, "Can I get that machine? Can I
Yes.
go in that room?"
Of
Yeah.
course.
So it's difference of how people perceive it.
Of course.
I think
It's a second set of eyes. You could look
Yeah.
at it that way too.
as physicians, we
Yeah.
need to adopt to it.
Absolutely.
Right? And I think it's going to help our lifestyle. And it's going to help, and also help patient care. Right? And the hospital system that's doing it, it's taken away so much human error and so much office staff. It's made their overhead less. But now, if it's some people are out of a job, so looking at it the other way around too. So I think it is a booming place. So if you want to do medicine, I think biomedical engineering and an MD, the next decade is going to be unbelievable.
Yeah.
I love it.
Unbelievable in this space.
No, I love it. Now, fun fact about Da Vinci, those robotics. So this is the year 2007.
Mhm.
I don't have a lot of money, and being in the finance world, you talk about stocks and things like that all the time. The hottest stock at that moment was ISRG, which is Intuitive Surgical something.
Okay.
And they would do Da Vinci machines. I'm sure they still do it. I haven't looked at it ever since because I was like, oh, what's the hottest stock? I was getting into stocks at the time. And
Yeah.
he's, this gentleman was like, he was a financial advisor at that time. I was junior to him. And he was like, oh, ISRG, and you could thank me later. It was like going sky high. I put everything, all the money I
Yeah.
dumped into it. And next thing you know, fast forward maybe a year from then, my stocks were like 80% down.
Oh my god! Whenever someone says like you're gonna thank me later, I'm always like, I don't think I will. I think I'm gonna be cursing you later.
So I've never forgotten the Da Vinci, the robotics that do surgical. I mean, they're amazing machines, by the way.
Yeah.
I know some urogyno physicians as well that use those machines. They're phenomenal machines, and at that time they were so new.
Yeah.
But now it's become a lot of hospitals. That's just a default. They do have those machinery out there, which is fantastic. So
I mean, AI is using operations of a hospital, how to run valet services, how to get patients checked in early.
love it.
I mean, it's just, I can't wait to see
Oh,
the next 10 years of what AI is going to do to healthcare.
Yeah, because the technology is changing like on a weekly basis at this point. Like it's not even like yearly anymore. Like it's changing all the time.
Yes.
It's going to be great.
Yeah.
I think it's going to be great. I
Yep.
think we'll, as physicians, I think it's going to be hard to adopt a lot of it, but I think it's going to be for the goodness
Yeah.
of it.
I definitely agree.
Yep. So with that good news, guys, we'll go ahead and end the podcast here.
Yes.
So thank you everyone for joining. Thank you, Dr. Shah, for taking the time out to come visit with us. Thank you, Priya, as well.
Yes.
Perfect. Thank you.
Thank you, Azhar.
Thank you.
Thank you, Dr.
for,
Shah.
it was absolutely my pleasure. I really
Yes.
enjoyed this chat,
Yes.
and I hopefully it benefits some out there.
Oh,
yes,
yes.
yeah. I think it will. I think this is a very, very interesting.
And very educational.
Absolutely.
I learned
Oh, I learned a
a
ton.
lot. Yeah.
Well, thank you
Learned a
guys.
ton.
You guys are awesome. Made me feel comfortable, and this was fun.
Yes.
It was a lot of fun.
Thank
It
you.
was a lot of
Yes.
fun.
All right. I'm gonna go buy some AI stocks.
Yeah.
I'm not gonna take that up.
Alrighty.